Welcome back. I'm Alyssa DeFranco with the Stephen and Alexander Cohen Foundation and will be moderating this discussion. During this session, we will talk with 3 clinicians treating children and mothers with Lyme and tick-borne disease. Let's have them introduce themselves, starting with Dr. Delaney.
Thanks for having me today. My name is Shannon Delaney. I'm a child psychiatrist by training, and I completed a research study at Columbia University investigating immune and infectious biomarkers related to neuropsychiatric disease. I've been on clinical faculty now at Columbia for 4 years, and I've been doing a mix of both clinical work and research work related to Lyme disease. Currently, I'm the medical director of the new Lyme Treatment Center called the Cohen Center for Health and Recovery from Lyme Disease and Tick-Borne Illnesses.
Hi, I'm a pediatric infectious disease physician based at Massachusetts General Hospital's Department of Pediatric Infectious Disease, who practices at Spalding Rehabilitation Hospital at a multidisciplinary pediatric clinic for children with complex Lyme disease and associated infections. Our clinic is part of, it's called the Dean Center for Tick-Borne Illness, which also has an adult clinic. The pediatric clinic just opened last year. Prior to that, I was at Boston Children's Hospital for 25 years. I thank the Cohen Foundation for hosting this wonderful annual conference and the LymeMIND organizers for again devoting a session to this important topic. And I'm honored to be part of this panel with Drs. Mulkey and Delaney.
Thank you, Dr. Mao. And finally, Dr. Mulkey, if you'd like to introduce yourself.
Yes, hi. I'm Dr. Sarah Mulkey. I am a prenatal neonatal neurologist at Children's National Hospital in the Prenatal Pediatrics Institute. I'm also the co-director of our congenital infection program, and I'm an associate professor of neurology and pediatrics at the George Washington University School of Medicine and Health Sciences. And I'm very happy to be a part of this panel, and we all have different areas of expertise that we bring to, I think, a very important discussion today.
Wonderful. Thank you all for being here. So let's get started. Dr. Mulkey, at Children's National Hospital, your team is treating many pediatric Lyme and tick-borne disease patients, along with conducting related research. Can you give the audience an overview of your work and the clinical approach that you take?
Yes, absolutely. And if it's okay, I'm going to share some slides that I prepared to kind of lead our discussion today. So I'm going to talk about congenital infections in general, and then we're going to move into Lyme disease. So congenital infections are an infection that affects the unborn baby. And moms can be exposed to these really just in our regular environment. We don't have to travel necessarily to catch these, but they're likely very under-recognized. And because of that, I think many women are not treated for some of these infections when we do have treatments that can really make a difference for the baby. And in some cases, they can be preventable. And so by counseling women and giving them guidance during pregnancy on how to avoid different congenital infections, we can really prevent some of the illnesses we see in our children. And it's very important to me as a neurologist because we know that congenital infections can really contribute to substantial abnormalities of the developing brain. And so I see babies with different malformations of the brain or injury to the brain that can be because of a congenital infection. Sometimes they can have hemorrhages, calcifications, abnormal growth of the brain where the brain is too small. And so I think with some infections like the Zika virus, which we'll talk a little bit more about, we remember seeing images of babies with microcephaly, and that's because their mom got an infection during their pregnancy. But we can also see that the offspring of women who have had infections in pregnancy can also affect neurologic development or behavior. And so it could be more subtle than having a malformation. And so those are the things we need to watch for. And so we know that the fetal brain can be vulnerable to maternal infection and illness during pregnancy. So when a mom has an infection or she has an inflammatory disease, this can impact the fetus and the fetal environment and cause increased cytokines in the baby. This can sometimes result in prematurity. We can see structural brain differences for some of these cases, but then also can see this as a cause of neurologic disease or psychiatric disease down the road as that child is growing up. And so Lyme disease in pregnancy, I think, is very important for us to consider. We know that Lyme disease is the most common vector-borne disease in the United States. It's a spirochetal infection caused by Borrelia species, which is transmitted by the tick, and we're gonna all talk more about that. Vertical transmission was first suspected almost 40 years ago, and we still do not know a lot about this. There has been some case reports of gestational Lyme disease and abnormal fetal infant outcomes. In some of these cases, they're able to culture the spirochete. Placenta spread has been demonstrated, but again, that's just rare reports. And so really the bottom line for this infection is that we know that infection can occur, because we can demonstrate it sometimes in the placenta and in the fetus or baby. But it's not clear if it causes a congenital syndrome or makes the baby sick from the in utero infection. And so again, the data is limited and we really need better data. But there are rare reports of newborns born to mothers with Lyme disease who have symptoms. They might have a rash or an enlarged liver. They might have positive antibody titers. There's been some autopsy findings finding the spirochete in different tissues. Often though, the placenta is not included in these studies, which I think is a really helpful thing to look at. There was one study of placentas in 60 women with positive Lyme disease serology in pregnancy, so probably one of the larger studies that we have access to. And in this study, they found 5% of the placentas to have spirochetes present, and in 2 of the 3 of them were positive by PCR for Borrelia burgdorferi. So how do we link gestational Lyme disease to pregnancy and child outcomes, which I think is really important? And this is really hard to do with the data that we currently have. There's variability in the study. So a lot of things that we have access to are just some case reports. We have some retrospective studies, some prospective studies, some population studies. The case reports, there's some evidence maybe of prematurity, of stillbirths, maybe infant rashes or congenital heart disease, brain injuries. But in a lot of these cases, it could be due to other things as well. So they're not definitive. There was a prospective study of 58 pregnant women with erythema migrans. All were treated. There were no malformations in these babies. There was 1 fetal loss and 5 preterm births. But whether those preterm births were related to the maternal Lyme disease, we do not know. There can be other reasons for sure. There was a serologic survey study of 1,416 mothers at delivery. And in this study, there was a prevalence of 0.85% being positive for anti-Borrelia antibodies. And so the 12 children that were identified there, 11 of those 12 were able to be followed up to 17 months, and all were healthy and developing well. But that is actually the only long-term child outcome study of moms with Lyme disease in pregnancy. And really following children up to 17 months, doesn't give us a good indication as to how they're going to do at school age and beyond, and all of the future things that children still have to learn after 17 months and how that neurodevelopment and behavior is going to go. And so we really need studies looking at childhood outcome following antenatal Lyme disease exposure. And so Lyme disease is treated during pregnancy. We certainly want to treat these moms, and there is evidence that this can improve fetal outcomes. There was a study of 95 pregnant women with gestational Lyme disease over a 22-year time period. And of those women, those that were treated had better outcomes. And so they saw more issues with preterm birth, fetal losses for those that were untreated. And so we certainly do want to treat women. They're treated with amoxicillin or IV ceftriaxone in pregnancy, and our maternal fetal medicine doctors would be the ones to manage them and follow those pregnancies. Unfortunately, this study, though, they did not look at placenta or offspring or follow neurodevelopment. So we don't have that kind of information as we would like from that study. But I think it's important that we learn from other congenital infections. And so I've done a lot of work with Zika. Since the beginning of that epidemic, I have followed a cohort of both women in the United States and in Colombia in their pregnancies when they had symptomatic infection, and I'm continuing to follow these babies that are now 4-year-old children. But we know that Zika virus is a flavivirus, and it's spread by mosquitoes, so also insect spread. And with this virus, as we may remember from the news of the malformations that we were seeing in babies born after these mosquito bites, about 10% of babies can have birth defects from Zika virus. And that's the child with the microcephaly or the other defects that can happen. But I think it's important that we recognize that 90% of the offspring of mothers who have Zika virus in pregnancy do not have those birth defects. But these are babies that were exposed to a mom that had an infection in pregnancy. She may have had a fever, she may have had a rash, inflammation. And so these are these healthy babies down here in my image here. And so what's important is we need to follow these babies long term to see if they're going to stay healthy, or are they going to become affected with different neuropsychiatric disorders, perhaps increased anxiety, depression, autism, behavioral problems, or other differences in their neurodevelopment if we follow them long term. And just in following the cohort of these Zika exposed babies, as they were nearing age 2, we were seeing some differences in their motor scores and language scores. So unless you follow long term, it may not be recognized. And so I think the same applies or needs to apply to following children born to mothers with Lyme disease in pregnancy. I think it requires having very detailed maternal data on the timing of infection, the symptoms of the mom, how she's treated, and really the progression of her infection during her pregnancy. And we need to have standardized fetal imaging evaluations, perhaps even quantitative imaging with fetal MRI, maternal and infant serology. I think evaluating the placenta for every case of a mom that has Lyme disease in pregnancy is really important. We want to get good birth outcome data, neonatal neuroimaging, and we can actually get very good images of the newborn brain without sedation early on. And so this should be part of these evaluations. And then most importantly, having real long-term outcome data, looking at multiple domains of development is very important for us to really assess whether there is any congenital effect to babies born with mothers who had Lyme disease.
Wonderful. Thank you for sharing that. It's a lot of very important information, which may be overwhelming to some. It's a lot to think about. And with that said, what do expectant mothers need to know if they suspect Lyme or tick-borne disease?
Yeah, I think it's very important if a mother is concerned about Lyme disease that she tell her doctor, her obstetrician. She should go be evaluated by a maternal fetal medicine doctor. Also engage with an infectious disease specialist to get the appropriate treatment during her pregnancy. And then I think it's important for you to make sure that her pregnancy is followed closely. If she has access to a center, like we have a congenital infection center here, and we're very interested to see moms and babies when there's a concern for congenital infection in pregnancy, whether it's Lyme disease or other congenital infections. And so I think being a good advocate for you and your pregnancy and your baby, and making sure that they get, good close follow-up through those early developmental years is very important.
Thank you. Advocacy is key, that's for sure. Thank you for your response. Dr. Mao, next question for you. You've been treating pediatric cases for many years. What is your approach to Lyme and tick-borne disease?
I said in my intro that I practice at a multidisciplinary pediatric clinic for kids with complex Lyme disease and associated infections. So at our clinic, we have providers in 3 different disciplines. Pediatric physical medicine and rehabilitation is 1, child adolescent psychiatry 2, and 3 pediatric infectious disease, as well as a combination social worker case manager. We see children and adolescents who have already been diagnosed with Lyme disease and have a variety of persistent symptoms despite standard antibiotic treatment courses. So for the first visits with new patients, we see the patient as an entire team at a joint visit, usually lasts 2 hours or more. This makes it easier and more convenient for patients and families, and it allows each of us physician members of the team to better coordinate our care. And frankly, it's also allowed me to gain the perspective and learn from my colleagues in different specialties. So for patients with persistent symptoms after standard treatment regimens, I want to get a very thorough history and review all past diagnostic testing to first decide if one, I think the original Lyme disease diagnosis is correct and the treatment was appropriate. And two, are there other explanations or contributing factors to their symptoms? So does there need to be additional evaluation to rule out other causes of, say, for fatigue, another infection like Epstein-Barr virus, or conditions like thyroid disease or anemia, or say for neuropathy symptoms, are there certain B vitamin deficiencies? And then if I agree with the prior diagnosis of Lyme disease, then based on a very thorough history and exam, I decide if the patient needs additional diagnostic testing to identify all possible factors that might contribute to their symptoms. This can include considering whether the patient needs additional Borrelia testing, possibly repeat Borrelia burgdorferi testing, or maybe testing for a different Borrelia species, such as Borrelia miyamotoi, or considering spinal fluid testing or head imaging in a patient with central nervous system involvement. And then I also consider other vector-borne infections that may or may not have been already tested for or treated. So for example, Babesia, Bartonella, as well as other regular infections, if you want to say, like Mycoplasma pneumoniae, Chlamydia pneumoniae, or streptococcal infection. And it can also include non-infectious factors, such as injuries, say a concussion with resulting neuroinflammation, or environmental toxic exposures. As an example, toxins produced by certain mold species. These are called mycotoxins, and the disease they cause, mycotoxicosis, is mediated through a variety of mechanisms that in certain predisposed persons, they might be genetically predisposed or otherwise, can have a large impact on infections like Borrelia and Bartonella. So putting all this together, I like to think about Lyme disease not just as Borrelia infection, but what might be better termed Lyme disease complex that can be viewed as what I like to say is a multiple hits model of disease. And the hits don't have to be acquired at the same time. For example, they're not all acquired with the same tick bite or even from a tick bite. There can be pre-existing infections that may have been asymptomatic or minimally symptomatic. Then with time and additional hits, at some point, your bucket, as they say, overflows and you develop Lyme disease complex. The workup can be a staged workup. You don't need to do everything at once. It's too much. It can be some of it pricey as well. But I like to do my standard routine testing for a Lyme disease patient with persistent symptoms. And then if I think there could be an ongoing active infection that might benefit from additional antibiotic treatment, either for Borrelia itself or for co-infections, then there are a variety of antimicrobials, mostly oral antimicrobials that I'll use. In rare cases, I'll use IV antibiotics. And if the response seems suboptimal, I will then re-examine my diagnosis and potentially add in other testing for some of the additional possible factors, like the mycotoxins that I mentioned.
As a follow-up to what you just told us, what do caregivers need to know if they suspect their child has or might have Lyme or tick-borne disease?
Thank you for that question. Let's see, I would say that if it's okay, I'm going to answer the question in terms of not just what parents need to know, but some points I feel clinicians need to know, because honestly, I was not aware of some of these things when I started seeing kids with Lyme disease, and I hope maybe I can provide some perspective to practicing clinicians who find the field of Lyme disease confusing. I will say, one, that presentations of Borrelia infection, I'm not talking here about Lyme disease, but Borrelia infection, can range from completely asymptomatic to markedly symptomatic with debilitating illness and every shade of gray in between. Lyme disease can be a relapsing, remitting illness with symptoms that come, go, wax and wane, which makes it confusing for both parents and physicians. Clinical diagnosis is paramount. You have to know the very wide variety of possible presentations of Lyme disease. both typical and atypical. And many of the atypical manifestations are, in my view, not so atypical. And in fact, some of them may be more common than certain well-known manifestations in the standard framework. So for instance, in my experience, I think cardiac manifestations are substantially less common than neuropsychiatric manifestations, which aren't so well appreciated. It's true that a large proportion of patients will have presentations that are well defined in the standard frameworks. Those are the manifestations that physicians are very familiar with. Skin, the erythema migrans rash, which importantly often does not look like a classic bullseye rash and is not present at all in a sizable proportion of patients. 2, cardiac that I mentioned. 3, nervous system, that's meningitis, facial nerve palsy, peripheral neuropathy, and 4, joint manifestations, Lyme arthritis. So a good majority of those patients will do very well with standard antibiotic treatment courses and have no ongoing symptoms or problems. However, there is a large group of patients with symptoms that don't fit neatly into that standard framework, but whose constellation of symptoms and signs are characteristic, and they can be anywhere from occasionally seen to commonly seen. And a thorough review of the scientific literature supports the idea of those various manifestations being caused by Borrelia or the associated infections that are often seen with Borrelia. Borrelia well deserves its title as the great imitator, so to speak. Let's see, I'll finish by saying that we learn in medicine the most important part of diagnosis is the history. The famous Dr. William Osler said, listen to your patient, they are telling you their diagnosis. In my view, that's very much the case with Lyme disease. The clinical history is paramount, and in my view, diagnostic lab testing is used to support a clinical diagnosis. And we need to keep in mind that a subset of patients with symptomatic Borrelia infection will not meet standardly used lab criteria for a positive antibody test. It's too complex a conversation for this panel, but suffice it to say that there is an evidence base in the scientific literature to support this view. And then I would just reiterate or say that parents need to understand there is a fair amount of controversy in the field of Lyme disease, with differing views as to how Lyme disease can present, how accurate is currently available diagnostic testing and standard recommendations for how to interpret that testing, and how best to treat Lyme disease, specifically in patients with persistent symptoms after standard treatment courses. So as a parent, you know your child best, and your own intuition means a lot. You may need to do your own research, and if based on this you're concerned that your child might have Lyme disease, you may need to be their best advocate in requesting evaluation for Lyme disease and testing, and potentially seek some additional opinions, including from clinicians who do take a broader view of Lyme disease and follow, if you want to say, a maybe more complex and nuanced paradigm than the standard one as to how Lyme disease can present.
Dr. Delaney, you have a lot of experience with PANS and PANDAS. Can you tell us a little bit about it and why it's relevant to tick-borne diseases?
Sure. Thanks for asking. So we know that after certain infections, kids can develop severe neuropsychiatric symptoms that often appear overnight. And the important point to point out, just like Dr. Charlotte Mao was saying, is that these symptoms can be very wide-ranging. So in terms of from a neuropsychiatric standpoint, they can often include new onset OCD, severe anxiety, severe depression, often with suicidal ideation, extreme aggression or mood problems. They can involve anorexia or disordered eating, ADHD or other cognitive problems, and also sometimes we see psychosis as well. Other more medical type symptoms can be involuntary tics, urinary problems, handwriting problems. So this condition of developing these neuropsychiatric autoimmune symptoms after infections was really first discovered to occur in some kids after a streptococcal infection. And so the acronym to describe that happening is called PANDAS, which is Pediatric Autoimmune Neuropsychiatric Disorders Associated with Streptococcal Infections. This was later expanded to include other infections as the infectious trigger, infections such as mycoplasma and also Lyme disease. So there's a new acronym that's called PANS, which stands for Pediatric Acute Onset Neuropsychiatric Syndrome. So I see a lot of kids with persistent symptoms after having had Lyme disease or some of these other tick-borne illnesses. And my experience with Lyme disease in kids is that actually the symptoms often appear not quite as acute as they happen with strep infection. So sometimes with strep infection, usually the change can kind of happen overnight or over the course of more like days. My experience with seeing some of these kids with tick-borne illness is that sometimes their symptom course is more smoldering. So instead, it kind of sometimes happens over the span of weeks to months and not necessarily days.
Thank you. How do you approach treatment for children suffering from PANS and PANDAS related to tick-borne disease?
So in my opinion, the first most important aspect of treatment is correct diagnostics. And that really usually is obtained from good history taking. So I agree with Dr. Mao on that one. And also I would second the opinion that, this is a very complex area of science that is still evolving every single day. So I agree that the parents and family really sometimes do need to serve as advocates, because in my experience, oftentimes patients and families feel a lot of invalidation from the medical community. So that's one thing I would point out, is that it's important to kind of trust yourself as a patient or a parent when you're going through this journey. But in terms of the actual treatment approach, I think that one of the things I'm sort of always struck by related to these tick-borne illnesses, including Lyme disease, is that there really needs to be an individualized approach, because there's no cookie cutter approach that really solves the problem with every patient, because really each patient is kind of an N of one and can present and look very differently, even though they've been exposed to the same infection. Generally, I see a lot of kids that do quite a bit better on antibiotics, and they can become quite stabilized on antibiotics, usually oral antibiotics, but also sometimes IV antibiotics for a brief amount of time. From a psychiatric standpoint, that's another important consideration, because the kids that I see often present with very severe neuropsychiatric symptoms. One thing that I have experienced in my work with these kids is that sometimes the psychiatric medications, so the standard sort of SSRI medications, which are selective serotonin reuptake inhibitors, these are medications like Zoloft and Prozac. Those standard medications are considered first-line treatments for anxiety and depression. However, oftentimes when a child has a history of Lyme disease or some of these other tick-borne illnesses, in my experience, these SSRI medications can often overactivate and cause a lot of agitation and a lot of suicidal ideation actually in these children. So that's something to keep in mind. I sometimes still use them, but I start them usually at a very low dose and go up very slowly. And oftentimes I pick other medications, such as Lamictal, for example, that's a mood stabilizing medication. But overall, in general, in terms of the treatment approach to these kids, I would say for the sickest kids who kind of fit the PANS profile from a symptom perspective, oftentimes a combination of antibiotics and then immune modulating treatment such as IVIG often have the best effectiveness.
Thank you for your feedback, Dr. Delaney. The next few questions are directed at interview, so wherever you feel comfortable, please feel free to chime in and provide an answer. Over the last few years, are there any new diagnostic or treatment approaches for pediatric patients that clinicians or patients should be aware of?
I would say in terms of research studies, looking at new diagnostic or treatment approaches, those are really needed. There is something called PD-LymeMIND, where the largest number of new published reports on pediatric Lyme disease are coming from. And it's a consortium of 8 pediatric EDs in Lyme endemic areas in the US. And they enroll children and youth up to 21 years of age who present to the ED for evaluation of Lyme disease. It could be early disseminated, or late Lyme disease. There's a clinical data repository as well as a biobank to collect blood and urine samples for future research. So there's a great infrastructure and organization to capture data on a large number of patients from multiple sites, and they have done a lot of their early reports have been on diagnostic testing. But I want to point out that when you interpret those studies, the patient population is restricted to patients who are defined as having Lyme disease on the basis of either a physician-diagnosed EM lesion or a positive standard 2-tiered antibody test in a patient with compatible symptoms. And those are considered symptoms in the standard framework for clinical manifestations of Lyme disease. Children who don't meet that case definition are classified as Lyme mimics. So it's just important to keep in mind that any study is, of course, limited by how the study population is defined. And I just said in my comments before that I feel there's a sizable proportion of patients who don't meet those standard criteria and can be some of the thorny patients with persistent symptoms, despite standard courses of treatment. So there really is an urgent need to study this population to better define in an evidence-based way questions as basic as what are all the varied ways that Lyme disease can present in pediatric patients, and how best can lab diagnostics be used to support or not a potential clinical diagnosis of Lyme disease? And what type of new diagnostic tools do we need?
For the first time in decades, NIH recently requested research proposals on diagnosing mother-to-newborn transmission of Lyme disease. Why is that so important?
Yeah, so this is wonderful that there's been funding put aside for very important work to look at the mother, the fetus, and the offspring then with Lyme disease. This is important because, as I shared with you, there's no outcome data. So we have very limited data from case reports, some smaller studies, some population-based studies, and really maybe looking at birth outcomes, but we have no long-term outcome child data. And so I'm really glad to see that there is an interest in funding these kinds of studies that we need so that we can make sure we're taking the best care of moms and babies that have Lyme disease. I mean, we need the guidance from good quality research on how to best care for them, what to look for, whether we need to be doing any special neuropsychiatric evaluations as the children are growing up, and preparing them for, when they're going to be entering school age, if there's anything we need to be watching out for. So this is very important, and I'm glad it's going to be happening. And hopefully we'll see some good data when we talk in the future.
I look forward to good data too. I'm sure we all do. And the final question from the session. From your perspective, what new research efforts hold the most promise for helping children and parents in the future?
I would say, just to reiterate what Dr. Mulkey said, that it's incredibly important that we do long-term comprehensive prospective follow-up studies of at-risk infants born to moms with Borrelia infection. And that in my experience in our clinic, a number of very sizable proportion of our patients will have family histories in the mom, in siblings, even going back to grandparents, where you have to wonder about intergenerational transfer or intergenerational transmission of Lyme disease. And I think that a number of clinicians do feel that the percentage of infants or percentage of children who've acquired their Lyme disease from mother to child transmission is likely larger than a lot of people and clinicians appreciate. So it's really an urgent area in need of study, and there haven't been studies for more than 20 years in the US looking at this, and no prospective long-term follow-up studies.
Right, it's so important. And then by doing those kinds of studies, then we can have guidelines for the evaluation of the pregnant woman, the evaluation of the infant, and for child follow-up following these early exposures. So without the information from these kinds of studies, we really do not have that kind of guidance to provide to families. But what I think we can learn from other congenital infections and what we know from other infectious inflammatory exposures in pregnancy is that we do need to be more watchful of infant and child development.
I would say from my perspective, I'm most hopeful about precision medicine approaches to persistent symptoms. So the idea of being able to develop and identify biomarkers to help better diagnose and also treat these persistent symptoms. And at the same time, I am also hopeful about clinical research involving alternative medicine approaches. There was a very interesting study that was published last year by Dr. Zhang and his group that looked at a lot of different herbal therapies and compared them to standard antibiotics. And this was a study that was an in vitro study that was done, but it found that many different herbs actually outperformed the standard antibiotics such as Ceftin or doxycycline. So I'm very excited to potentially do some clinical research studies involving some of these non-antibiotic treatments and seeing how effective they are at persistent symptoms related to Lyme disease.
And I'll just add on to Dr. Delaney's comments. I agree that treatment studies are very much needed. There is general consensus that a proportion of patients receiving standard courses of treatment will go on to have persistent symptoms, sometimes called PTLDS, post-treatment Lyme disease syndrome, or alternatively just persistent Lyme symptoms after standard treatment. The proportion of patients who go on to have these persistent symptoms is commonly stated as being in the range of 10 to 20% in adults, but published studies have actually found a higher rate. For example, Dr. Alcott's group at Hopkins in a prospective cohort study reported persistent symptoms in 36% of patients at 6 months follow-up after a 3-week course of doxycycline for an EM with systemic symptoms. So it's a substantial proportion of patients who have problems with persistent symptoms, and especially in children. There really do need to be treatment studies in all patients, but specifically in children, there are very few treatment studies. And so whether it's traditional antimicrobials or alternative treatments, which I also fully believe in, those are studies that really do need to be done very urgently.
Wonderful. Well, thank you for your input. And thank you to each of you for the time that you dedicate to the research and the treatment of pediatric patients. As a mom myself, and as a member of the Stephen and Alexander Cohen Foundation team, I really appreciate all the time that you've dedicated to this topic. It's very important, and we're appreciative to have you on board here.